welcoming you to kind of stay on because we have a specific case, a session that we're going to look at where it may not be possible to, let's put it this way, put people into COVID-specific settings. These are a special case of people who are undergoing their cancer treatments. Oncologists, oncology-related treatments are also at very high risk because of their immune status of contracting COVID-related infections. And so therefore, what do we do in that kind of a setting? And so therefore, we have with us, I can see Dr. Rawal from Rajiv Gandhi Institute already join us. I believe we have Dr. Gupta, Dr. Babu, and Dr. Warrior, and Dr. Ved all coming in. We need the specificity of COVID hospitals, but we also recognize, let's put this way, special circumstances, and oncology and cancer care becomes a special case within the overall response. And so therefore, let me turn to Professor Rawal. Where do you think, given the recommendations that are being talked about earlier on, that we need to avoid admixture, we need to avoid having COVID-related patients in our regular facilities, and we need to direct them to specific ones? How do you deal with it as a hospital, a tertiary care hospital for cancer?
Bobby, we work in a pure cancer center, exclusive cancer center. We had a meeting as soon as this pandemic started, and we were going through the many guidelines from abroad also, and we have National Cancer Grid guideline, which they had a meeting, all the cancer hospital, they had a meeting like this meeting. There was a Zoom meeting, and then they came up with many facts and suggestion for the cancer hospital who are dealing such patients. Because we have patients who are on chemotherapy, who have had bone marrow transplant, and who do require continuation of the treatment, and the surgery. Surgery itself comes in a semi-emergency type. It's not that like a cold surgery. So I had talked with my friend in MD Anderson also. What are they doing? And that is what, this is how we are dealing right now this situation in our hospital. We are having trials in front of emergency and in front of reception. Before any patient comes, he goes through that trials, and the history is taken about any contact, fever, sore throat, or anything. If it's suspicious, patient goes to the nearby hospital. Like we are in Rajiv Gandhi Cancer Hospital, so he goes to Ambedkar Hospital. And if the patient is cool, and other thing that we have followed is the follow-up patient. We are not taking them. We are telling them, you can talk to us on phone, and they will connect to the concerned doctor. And we are telling them to delay their follow-up for 2-3 weeks till this situation settles. And this is how our attendance of the OPD has come down to only 25% now. It used to be like 100%, then the attendance is only 25 patients. New patients we are taking only when if they are domestic. They are national patient, we are not taking international patient at all. We are sending them for quarantine or other hospital. Like if they have any history of fever and all, then they, unless these patients are actually staying in Delhi for few months here, like Nepalese patient, they come here, they stay here they are there for a few months, then they are coming to us. Otherwise, they are going for quarantine. As far as chemotherapy is concerned, the guidelines and which we are following is that if the patient is new and chemotherapy can be delayed, we ask him to wait for 2-3 weeks or maybe a month. Otherwise, he goes for chemotherapy. If the patient is old patient who is on chemotherapy, we are taking him. Now, bone marrow transplant, we are not doing transplant for thalassemia, but if the AML, like emergency situation is there, the patient will go for bone marrow transplant. And in the surgery also, if the surgery is cold surgery, if suppose there is a small kidney mass or there is a small tumor which can be postponed for 2-3 weeks, we will not take him. We will ask them to come later on. But otherwise, we will operate them after taking all the precautions.
So what I'm hearing from you, Dr. Rawal, is this, that by and large, you're only restricting yourself to those that need to be done.
Yes.
Anything that can be pushed out, you're kind of delaying or kind of staggering it out. Professor Ved, let me kind of ask you this. Within this whole COVID scenario, I know that, and operationally, I mean, the Rajiv Gandhi Institute has already kind of said how they're kind of triaging out or sequencing out. Where do you think we will be when we have all our facilities really running full, and we also have, and our cancer patients are not going away. They will need continuous care. How do we kind of make sure that we are protecting them? Postponing is one side of the story, but how do we actually institute protection measures within those facilities?
So the protection measures for these patients would be part of the general guidelines which are already available, that keeping the social distance and etc., use of the protective masks and all that. These are the general guidelines which are in place. So nothing new as far as our patients are concerned. The same general guidelines would prevail for this group of patients as well. Now,
would you have some guidance? So would you have guidance for the families of these patients also?
So what we are generally, sort of encouraging the families are that try and restrict the number of attendants who are coming to the hospital. So we know that our hospitals have one of the issues is the large number of attendants who come with the patients as the caregivers, but we are trying to encourage them to be with only one family member if preferable, because if it is an outpatient visit or a daycare visit, one does not need more than one family members. Even on the inpatient basis, the same instructions are being applied, and the families are being encouraged to be with the least number of family members, maintain the social distance, and report the symptoms, if at all, which are applicable to anyone in the society at the moment. And also practice the hand hygiene and etc. So the general guidelines are applicable to this group of patients as well.
So the general guidelines is what you are kind of really reinforcing all the time to everyone.
Absolutely.
Right. Before I come back to you, sir, let me ask Dr. Warrior. I mean, we've heard the general guidelines, the management of the number of people that are in contact with the patient. We're also looking at how the postponement of the elective procedures are also being put out. But by and large, if people are on a schedule, then they have to be on a schedule, right? And then that's where your entire therapeutic regimen actually hinges on. How do we ensure that when people are moving, what is it that you want people to be aware of when they're coming in from their homes and into the facilities, or when they're in the hospital and going into the procedures? What is it that you want to be particularly done now?
If the patient is not for any, the intent of treatment is not a curative one, and it's only a palliation, and if the patient has no symptoms at the moment after receiving some cycles of chemotherapy, definitely we will postpone such chemotherapy schedules. And the next one is about the radiations. Some of the radiations which have already started will be continued without any interruption. And the new patients who are waiting for radiation to be started, again we will triage, like those who are having curable malignancy and schedule cannot be changed much, will be offered radiation. And if something like the prostate cancer and all, we can start a new adjuvant hormones, and then again 1 or 2 cycles more, so that the radiation can be pushed away. For surgeries, some of the surgeries, again, early breast cancer, we may have to offer surgery. Such patients, at the moment we are offering them surgery, but if it is very early and we think that we can postpone surgery for another 2 weeks, we will definitely give dates later than 2 weeks. This is what we practice now.
Right. Dr. Gupta, I mean, given that you're both a center where people are coming in, but you also have an education component there. The things that have already been said by Dr. Rawal, Professor Vaid, Dr. Warrior, is there a guideline or a communication that is already out there for the oncology community on the lines that of the practice that are already there? Because you can't postpone some things in this space. Is there some guideline already out from the community side or the oncology associations?
So if I understand you correctly, your question is whether there is already formal guidance on what oncologists should do in the current scenario. And my answer to that is yes and no, because the situation is evolving so rapidly that everybody is finding it hard to catch their breath. But yes, there is some guidance. There is guidance from the American Society of Clinical Oncology. There is very nice guidance from the National Health Service in UK about what oncology centers and oncologists should do with their patients. There is also guidance from the University of Washington at Seattle. There is guidance from China. But in this sort of a situation, one cannot adhere to the old mantra of level 1 evidence and the highest standard of practice. We have to all improvise, and our patients fortunately are understanding that we have to improvise and we have to deliver care to the best of our ability. And I think everything that the other panelists have said was very valid and appropriate. At Tata Memorial Center, we are trying to screen patients to see that those with fever and other symptoms suggestive of COVID-19 infection do not mingle with the others. We are trying to reduce the crowd that usually collects in all our hospital OPDs. We are calling patients at different points of time. We are prescribing remotely. They just go to the pharmacy and they directly collect their medications. We are trying to convert some of the intravenous regimens to oral regimens to reduce the exposure of patients in the outpatient clinic to a large gathering. We are trying to carry on with those treatments where irreparable harm will come to the patient if the treatment was not carried out immediately or in the next few days. But we are prioritizing, and some of the other treatments are then getting somewhat postponed. We are running we are actually running a call center in Tata Memorial Center, both in Actrek and in Tata Memorial Hospital, where we are providing telephonic consultations to patients. Our patients come from far and wide from all over India, and that's a little bit of a challenge. And unfortunately, many patients were caught in transit, and we are trying to help them the best that we can. One situation that we are facing in Mumbai, and I think others may also be facing, is the relative shortage of blood and blood products, because even the donors are finding it hard to make their way to the hospital. We are trying to mobilize the community so that we have enough donation of both blood as well as blood products as then when they are required. So we are prioritizing. We are trying to reduce the crowd in our OPD. We are trying to deliver treatments that will result in as little time spent in the hospital. And if the visit can be postponed, then that's the best thing that we can do to our patients at the current time.
Thank you, sir. May I just quickly turn to Dr. Babu? And you have made an excellent point. And I want to, when I kind of come to summarizing it, you have made something that I think should be a public service message, and going back to our thing. But before that, let me just hear from Dr. Babu and then summarize what this group of eminent oncologists have spoken. Dr. Babu from Kidwa Institute.
Yeah, Doctor. Well, the thing is that I agree all the eminent speakers what they told. Similarly, in the same lines, what we are practicing. The question is, now because of the 21 days lockdown, the number of OPD patients or whatever patients we are seeing, it has reduced almost 90%. So we are seeing only about 10% of patients. What will happen if we open this lockdown and open the gates? For example, for a medical oncology OPD in Kidwai, we will see around 500 cases a day with the 6 consultants sitting. Now, if you go on that, so even if you try to reduce by 50-60%, you will be land up in saying around 300 patients. So how are we going to manage when all these things open up? So what we are doing is now currently we are seeing all the guidelines and trying to postpone it for 3 weeks. So now what we are going later on, that is the biggest question. So currently what we are following is the same thing what others told. Like we are doing triage initially, and we are, running forward chemotherapies, prioritizing the patients who are in curative intent to give them more treatment. Palliative, we are trying to postpone. So those things we are doing, but I don't know how we are going to handle when these things go. So that's the thing.
Right. Thank you, Dr. Babu. I mean, you raise another operational question. It's almost like we are pressure cooking our number of patients by holding them back, when we come into a point where people think that it's going to be safe to go out without having adequately informed people that the 21-day lockdown is not a cure, but is only buying time and getting us a little bit more of space and resources to do it. It is going to be very, very important to manage the flow of especially vulnerable people to be turning up into healthcare settings where they may be at risk of contracting infections. And so that's one part of it. But I want to kind of, we've had 5 very eminent oncologists from different parts of the country come together. Dr. Gupta, you kind of said that we have guidelines from the American College, we have got the NHS, we have got others. I think it is about time. We don't need to wait for others, but at least a rough and ready operational kind of guidance to be given on certain aspects of our care for those that are with cancer-related interventions, that these are the do's and don'ts, and I'd rather that a group of you come together and put it out there, and we can kind of support you in getting that out. But not having that right now and saying that we have external clinical guidance alone is probably a wasted opportunity. And I want to kind of encourage you to consider together, coming as different institutes and leaders of the field, to be able to put together a guideline. That's one part. The second part is this, and this is something as a public service. Blood donors. Yesterday, there was somebody who needed blood in a particular institute in Delhi, and for 12 hours they were asking for a blood donor, and nobody turned up. And the reason why people didn't turn up was they're not classified as essential workers. So in figuring out how a potential blood donor is also given a priority to move to a hospital is something that we need to probably pick up. And that's one thing, Dr. Pabin, that's one thing that I would very particularly take up as something that needs to be communicated to our decision makers and to our district level authorities, that if somebody is going to donate blood, if it's a designated blood donor, especially for oncology or other related emergency services, that they should be given a pass without fail. Dr. Gupta and Dr. Wen, to close this out.
I make a point here. The point regarding the guidelines being available from India, there is a document which is being prepared by the Indian Cooperative Network, and that is being put out. That's again based on the internationally available resources, because as Sudeep has said, that there is nothing which is written as a document, and we are learning every day. But there are some guidelines which have been put up by the Indian Cooperative Network. They are available in the public.
Right. Thank you, sir. Dr. Gupta, you wanted to close out on this one.
So actually, on the blood donation bit, I can just share what we have done. We have established a hotline with the Commissioner of Police of Navi Mumbai, and we already knew him earlier, so that helped. And anybody who wishes to donate, the request for donation is up on Twitter, on our website, on a special email, on WhatsApp groups. And we have a ready list of donors who are willing to donate to us, and we have the vehicles to pick them up, and the police will not stop them.
Thank you so much, sir. I mean, this brings us to kind of an end for this particular focus session on a particular cancer thing. Dr. Babu, you wanted to say something. I see your finger. Yes. Unmute yourself, Dr. Babu.
Yeah, I think as
and I will come back to you, Dr. Kumar.
About the blood donors. About the blood donors, I think all cities doesn't have so much facility. What we can do is we can ask the blood, banks to send a SMS to that person who is donor, so that he can show to the police and telling that I am going to donate the blood today, such and why don't you let me in and go off? Like that, they can do that.
Fair point. And operationalizing this is something that at IHW, the organizers of this virtual conference, will definitely write both to the Ministry of Health and to the various other responsible authorities to figure out a modality for streamlining this. Dr. Ved, the last word to you on this one.
So for the oncologists who are practicing in the hospitals, because there would be some cases who would come back to the hospital with fever and suspected symptoms, there is a learning which is coming from Italy. What they were doing was that in the ER, in the emergency rooms, they were taking up these patients as suspected cases. would send the sample for testing for COVID and would be kept in the triage, would be kept in the emergency room till the report would not come, and treat them as on the merit of the infection or the suspected infection. These patients would never get mixed up with the general oncology patients. They would never move to the wards. They would never move to the general area before their report would come in. And then that's a very valid point. I had actually logged in a little earlier, and what Harsh Mahajan said, that having these patients mix up in the hospitals, in a general hospital, would actually be a disaster. Imagine an oncology patient who's actually a febrile neutropenia who comes into the emergency and also has a COVID or doesn't have a COVID. It's a complex problem. So the oncology patients have a severer infection, would be more complex, would be difficult to diagnose, and would pose a real challenge. So the ER has to be very, very robust in every hospital to identify these patients, do the testing, and then only move these patients into the facilities. Otherwise, it's going to be a disaster.
And absolutely, thank you so much. I mean, Dr. Rawal, Dr. Vaid, Dr. Warrior, Dr. Babu, Dr. Gupta. I mean, this panel on oncology as a special case within a larger pandemic situation, and how we manage that has been an eye opener for me too, in terms of looking at the specifics. Sometimes the specific sticking points that actually make the difference between a good outcome and a complete kind of a waste of all the effort that has been put into getting somebody into that particular moment of well-being or in their journey towards well-being. Thank you so much for being there.